Good morning, good afternoon, good evening. Welcome to Chatham House in London. My name is Robert Yates. I'm the Executive Director of the Centre for Universal Health here at Chatham House. And it's an absolute pleasure to be hosting this event today. And we're discussing the very important topic of ensuring equitable coverage of COVID-19 vaccines, particularly for refugees and migrants. It's only just over sort of 2.5 years ago, that just before the pandemic started, that world leaders met at the United Nations to discuss the important topic of universal health coverage, that everyone should get all the health services they need without suffering financial hardship. And the last 2 years has demonstrated why this is so important, that literally everyone on the planet accesses a full range of health services. All the promotional health services, preventive services, curative, rehabilitative and palliative care services. And the COVID-19 crisis has really exemplified why that's so important for ourselves and our own families, but also for societies as a whole. But we're conscious that there are population groups who sadly often sort of get left behind, that aren't included in national health systems. And one particularly very vulnerable group are migrants and refugees, who have often had to sort of flee their homes in difficult circumstances, live in poor housing with poor working conditions, and are excluded from national health systems. And them not being able to access COVID-19 vaccines both represents a violation of their human rights, but is also bad for host nations and as well, given the public health implications of that. And of course, that we've seen that in the terrible unfolding crisis from Ukraine at the moment, a huge increase in number of refugees in Europe, with I think about 10 million people having left their own homes, and about sort of 3 or 4 million of those having moved to other countries, and how vital it is that those populations are immunized, not only against COVID-19, but other conditions as well. So we're delighted to have this panel here today to discuss this extremely important topic. I should say that today's meeting is on the record. It's not following the famous Chatham House rule. So feel free to report on what's said today. In fact, we would very much encouraging it through the likes of Twitter and your favorite social media channels. It's also going to be a very interactive discussion today. We're very keen to hear your views from the audience about tackling this important topic. And so we'll be asking you to pose questions of our panel through the Q&A function. So don't use the chat function. If you can use Q&A to ask your questions. And if you see any questions that have been asked that you particularly like yourself and you'd like to hear answered, if you can upvote it, if you can click the thumb, that way we see the more popular questions, rise to the top. And we'll also give you the opportunity, if you like, to come on air and ask your question of the panel as if you were in the room with us, and we were holding it as an in-person event. So we'll be very much encouraging you to ask questions, and we'll be sort of taking Q&A, I guess, in about half an hour or so. But first off, if I could introduce my esteemed panel today, and I'm delighted to have with me 3 panelists. First of all, we have Dr. Kanakporn Kujaren, who is the lead country support and capacity building at WHO Health and Migration Programme, speaking to us today from Geneva, and has a tremendous experience of providing health services to migrants and refugees, particularly having worked with refugees in Myanmar and also in Pakistan. We also have with us Tala Jalal, who is currently the Senior Manager for Public Policy Engagement at Gavi, the Global Vaccine Alliance, where he advises the Gavi Secretariat and COVAX facility on humanitarian issues. He's also worked for MSF extensively in the Middle East. And finally, we have with us Dr. Apostolos Vezis, who is the Executive Director of Intersos, which is a non-profit humanitarian aid organization in Greece, with frontline experience of providing services in Greece, but also extensive experience having worked also for MSF in a number of emergency settings across the world. So welcome, panelists, and I'll be handing straight over to you now, if I may. I think we said if you can speak to us for about, say, 8 minutes each to give us your perspectives from your different organizations and your experiences, and very much encourage Q&A to come. I'm delighted to see your questions come in already. So top tip, if you want to ask a question, get it in early, because then there's a better chance it gets upvoted. So don't be shy. Do please feel free to ask your questions. Jum, over to you first. So what's your perspective from WHO?
Well, first of all, thank you very much for inviting. Let's first, before we talk about perspective, let's talk first what we do in our program, just very quickly. So basically, what WHO has at the organization is the department that deal with refugees and migrants that sit at the Office of Deputy Director General, so that the program can work across the organization, as migration is a cross-cutting issue. So with that, myself, I'm cover country support, but also on the vaccination. So basically, what we have done, a lot of work so far. You probably have seen that we have published the interim guidance on COVID vaccination in refugees and migrants. We also recently just published another operational guide on strengthening vaccine uptake and demand in refugees and migrant population. So from our side here, I think, as you have said rightly, I think there's a lot of issue of equity. There's a lot of issue of the inclusion policy, but beyond that, there's also the issue of personnel and at the community, at the personnel and community level. So let's look at let's look at the global level, where we see here, when we talk about the global vaccine equity, we see so far, I'm sure that Taha is going to talk more about the COVAX, but I would just touch very quickly about right now, as of the end of March, we have 11.1 billion doses of vaccine that have been administered. But when we look at, it sounds high number, but when we look at that, we look at the average of number of people who receive the primary doses, it's 65% is the global average. But when we look at country low income, high income, we only see 15% of low income countries that have received primary doses of vaccine. So basically 35% of the world population that have not received, but with this one significantly disparity between high income and low income, and also between regions. For example, in the African regions, as of today, as of end of March, still 83% of the population still have not received a single dose of vaccine. 51% in the Eastern Mediterranean, but only 15% in the Western Pacific, 34% in the European region. Or if you look at by age group, at risk group, if you look at 60 years old and above, we see that an average 74% of high income over 60 years old receive vaccine, but only 15% in low income countries. So there's a disparity in terms of global vaccine equity. But when we also see with this one, the WHO and partners, including Gavi and UNICEF and partner, has set up the policy that by the 30th of June, 70% of the population, the world population, should receive vaccine. So with this one, over time, for us, our team have followed up on the vaccine rollout from the very beginning, when the first dose become available since December in 2020, throughout until countries submit their plan, the national vaccine deployment and vaccination plan, up until how the vaccine has been rolled out, what it is in practice, and what until now. So what we see is that as now vaccine become more available, but there are also many bottlenecks, that there are many countries that they're not going to meet the 70% that to be set as a goal. So when we look down into country by country, what we see is that now 34, we see that going to be about 34 countries that will not meet, that right now are unlikely, that now the coverage is less than 10%, and unlikely to meet the 70%. So these are countries that mainly are highly hosting number of refugees and migrants. Many of them are countries with fragile state, with conflict related. For example, you have like Afghanistan, DRC, Ethiopia, Kenya, Nigeria, and Sudan, for example. So the concentration right now is going to be into these countries. So when we look down further into the country-wise, country policy itself, the issue of inclusion policy that have been already talked from at the introduction of the session. We also have been follow up on this inclusion policy. What country have planned when they submit the proposal, the plan to COVAX for approval, the facility. At the beginning, when we see it, but we saw a positive evolution over time. When we start the review of that in January, February, and March, we see less than 40% of countries had explicitly include migrants into their plan. For refugees, we see more number, over 50%. But when we look at irregular migrant or undocumented migrant or migrant that live in the country illegally, so we saw only 17% that the plan have explicitly include the population. So over time with this, we see some improvement, but what we don't see the improvement is irregular migrants. So with this one, then and also another level that we look further into this is look at the personnel and community level. Look at from the perspective of the refugees and migrants themselves. We saw a lot of barriers that prohibit or preventing them from access to service, to vaccination service. For example, the issue of legal, administrative, financial, logistic, a practical issue or technical issue. For example, for the registration, you require the ID card in many countries, and with that, they don't have the ID card or the card that they are living legally living in the country. Many of them do not have such a thing, and then you also have the issue of the fear that they may be deported. Well, the issue of high population movements impacting the ability to access to vaccine, or in some cases, when they cross from one border to another, they got one vaccine. When we cross the other, they got another vaccine. So there are different extremes of the issue of the legal, administrative, and financial and logistic issue. Excuse me. Then there's also the issue of barriers in personnel and social and cultural belief. In some culture, they don't want to get vaccine. In some culture, they have concern about it's not the culture, but the personnel itself. They have the issue of concern of vaccine safety, for example. And another barrier that has been going on also is related to knowledge, information, and awareness. So there's a lot of misinformation that's been ongoing. There's the issue of lack of awareness and availability of vaccine. They don't know where to get vaccine. They don't know whether it is their right that they can have access to vaccine. So with this are kind of a barrier that we have seen that it beyond also the barrier within the health system, the capacity, the bottleneck that there is in the health system itself. But with this one, we also have seen some lesson learned from this COVID vaccination. One is that we must address the vaccine equity, the distribution of vaccine among the rich and the poor countries. We also have to address the issue of the absorption capacity, the bottleneck that preventing in getting vaccine into the arms of the people. But we also issue the policy, inclusion policy in itself is not enough, but we have to do more in addressing demand and uptake, confidence on the hesitancy on vaccine. So these are the areas, and the other area that we see that should be addressed also is the issue of the data. We don't have, as today, we still do not have what is the uptake, what is the coverage of vaccine in this population. Data is just not collected by migration status. In some country you may have, in some community you may have, but overall, we still don't have a clear picture of how many refugees, how many migrants have actually been receiving this vaccine. So in terms of positive evolution, I'm about to conclude now. What we see so far is that from the moment we see the improvement in terms of the inclusion over time. We see the improvement of supply over time. And the concentration right now is what we call here is a pool now. Before it's a push of getting vaccine out, but now it's a pool is to try to get country to be able to absorb the vaccine in order to vaccinate people. But the issue also is we also see a lot of policy. We also see issue of the intervention that try to address the issue of demand and uptake in this population. So with this one, we have put it in our guidance, operational guide on how we should address that. So I will stop here, and then I'm happy to address a question if you have. Thank you very much.
Thank you very much indeed, Joe. I do have one or two questions. I'll perhaps come to the other panelists first, and thank you very much for really giving us such a fantastic introduction to the scandalous level of vaccine inequity between countries, as you've already shown, but also within countries, and that with certain groups being left behind, sort of particularly, as I say, refugees and migrants, and what can be done to address that. You touched briefly upon the distribution of vaccines around the world, and Gavi's been extremely involved in that, of course. So if I can bring in Talat now to sort of give your thoughts on what can be done to improve coverage, particularly of migrants and refugees.
Thank you, Rob, and thanks for having me on the panel. I would like to begin by highlighting a few data points and some background on global efforts so far, and then I will share my reflections as well on some of the systemic challenges. Now, when we started, designing the COVAX facility, from the very outset, there was a provision in the design for a 5% buffer of vaccines, and this is at a point in time when there was no successful vaccine candidate or financing for global distribution. This buffer was for covering the unknowns, so to speak, in a future global vaccination strategy. Now, we anticipated that some people will be left behind, as we know from our experience with routine immunization, where you still have, so-called zero-dose children, many of which are among displaced communities. But we didn't know the full scope and the profile of the population of concern as yet. So as the design of this potential mechanism was developed by Gavi, WHO, and UNICEF, we also brought into the mix the Interagency Standing Committee, or the IASC, which is the highest level humanitarian coordination forum of the UN system, and includes actors like IOM and UNHCR. And over time, the COVAX buffer began to be oriented towards humanitarian contexts and the hardest to reach populations. And this was also driven by our understanding of the evolution of the pandemic and vaccination coverage, which Jom has touched on, with a view to making sure that refugees and migrants are also reached. We wanted to make sure that there is a possibility for non-governmental actors to deliver vaccines as well. Given that many of these populations are invisible to health systems due to lack of documentation and other factors that Jom also touched on. And this is one of the ways that COVAX humanitarian buffer stands apart from the rest of the multilateral effort for vaccination. It is open, not just for governments, but also, for humanitarian agencies to apply for COVAX-funded doses to reach the hardest to reach populations in humanitarian situations, including, of course, refugees and migrants that are in vulnerable situations. Now, a bit about the needs and the gaps globally. The ISC last year estimated that roughly 167 million people, including refugees and undocumented migrants, but also those in active conflict zones and stateless people, were at risk of not getting access to COVID-19 vaccines as part of national efforts. This year, in 2022, the estimate was revised down to roughly 155 million people. Now, of course, this number is subject to shocks due to new crises and displacements like the one in Ukraine, but it does give us an idea of the magnitude of the challenge. I do want to note that it is somewhat encouraging that we saw a downward revision of the global figure this year from 167 to 155 million. And this is primarily due to the population under UNHCR's mandate, basically registered refugees being included in national vaccination plans to a significant extent. But at the same time, there's other subgroups within this number, and Jom also mentioned undocumented migrants, for example, and also nearly half of the 155 million are people living in areas controlled by non-state armed groups. Vaccination coverage among these groups is really woefully lacking. Broadly, when we look at lower income countries, which is where most of these people are, 17 countries, including, for example, Afghanistan, Somalia, Ethiopia, DRC, host nearly 70% of the people in need of humanitarian assistance globally, including a large number of displaced populations. And these countries account for almost 25% of all unvaccinated children in the world. And as we know, routine immunization, and Rob, you would know this very well, is really the foundation on which other health interventions are built on. And when you see this next to COVID-19 vaccinations, you do see strong parallels. Indeed, these same 17 lower income countries have received only about 12% of the COVID vaccines that have been delivered to countries with a humanitarian caseload. So countries that are poorest and host most people in need of humanitarian aid also have the lowest access to vaccines. So really a very problematic picture. And here I also want to remind the audience that the toll of the pandemic has been very unequal. For every life lost in a rich country, another 4 people have died in a poorer nation. And this is according to an Oxfam report from last month. Now, in terms of the global response and COVAX, in the 28 countries with a humanitarian response plan, including refugee response plans, nearly 52% or 280 million COVID-19 vaccines have been provided to their national health systems through COVAX, making it the leading source of vaccines in humanitarian contexts and lower income refugee hosting countries. Within these settings, the humanitarian buffer that I mentioned at the outset is now also being mobilized to reach the hardest to reach. So far, we have delivered vaccines via this mechanism to Uganda and Iran to provide coverage to refugees hosted by these countries. And while this is a demand-driven mechanism and each request for vaccines is assessed by an independent panel of experts, there are challenges that have meant that this mechanism is so far relatively underutilized, particularly by non-governmental actors. I will mention a few challenges that are relevant to this discussion. For example, in politically complex or in conflict settings, importation and regulatory approval in the absence of a government as a partner is incredibly complex. And it has never really been done before with a novel vaccine that is not previously in use at the national level. And here I'm talking about bringing in products or vaccines and delivering via NGOs or UN entities. So there is no blueprint for doing that. And we are building the ship as we sail. Another challenge is that COVID-19 vaccination may not be an operational priority in some acute humanitarian situations, especially if you were to try and go in with a vertical program. So we really need to think hard about making our processes, ranging from import authorizations, legal contracting, reporting requirements much more lighter and tailored for humanitarian and refugee response. Finally, as the pandemic evolves, one of the potential scenarios that is worth considering for contingency planning is, flu-like annual vaccination campaigns if we end up in that situation. And I say that because there is no financing model at the moment for doing that in low resource humanitarian settings. How do we reach hard to reach or on the move populations repeatedly with multiple doses, and how do we deploy, for example, mRNA technology with complex ultra cold chain in certain contexts? So, in conclusion, we do have quite a few lessons learned in terms of what works, what doesn't, and also a number of innovations such as the humanitarian buffer, the no-fault compensation scheme managed by WHO, among others, that we can try and leverage for our preparedness for future threats. But we cannot do that fully without, I think, partnerships and openness to working outside the purely state-based architecture. So civil society and humanitarian partners are, I think, key to this. If the last mile remains uncovered, which it still very much is, we are, I'm afraid, in a pretty vulnerable position as a global community, faced with potential new variants, but also, the next pandemic, which is an evolutionary certainty. So I will end here and look forward to questions in the Q&A session.
Fantastic. Thank you very much, Tala. And I think you show very clearly the huge difficulties in providing vaccines, particularly in post-conflict states and fragile states where a lot of migrants and refugees live, and just how difficult it is to do that through government systems, particularly where it might really be the case that things are so fragile and that there are wars on that it isn't the top priority for the government, and how essential it is to work with and through CSOs. And someone with great experience of that, from the frontline perspective, is Dr. Apostolos Avazis, who's, as I said, doing extensive work in Greece with his organization. So how's it from your perspective on the front line then, Apostolos, in terms of the difficulties in covering migrants and refugees?
Yeah, thank you very much, Robert, for the introduction. Also, thank you for the invitation. I would touch maybe in the beginning a few points that are not related with migrant and refugee vaccination. I would like to touch that today is the World Health Day. Secondly, I would like to remind ourselves that the majority of the people around the world, do not have access to healthcare in general. So let's not go to percentages, it is half the world or 3/4 of the world on that. And I think a very big lesson that we learned from COVID is that COVID did not discriminate anybody. The COVID did not ask any passport, any identity card. It was documented, undocumented, infected everyone, and created a pandemic, and is keeping us alive to have also this discussion. So we are not learning from those situations. We're not learning from those conditions. I'm saying that because the world showed once more the nakedness and being unprepared to deal with health issues. I think we know as a science how to manage. We know what tools we need. We have the tools available, and still the pandemic is controlling us. Why? Because not everybody has access to healthcare equally, and in that case, we will be managing our life better. And just to discuss the last point on that is that the health economics will be much better, and we'll spend this money for other purposes. Now, coming back into the what does it mean on a front line? Tal Habifu and also the colleague from WHO mentioned barriers and issues related to war, issues to distance, issues to management of the cold chain, etc. Here we're talking about the European Union. We don't talk about all those barriers. The barriers are political. It is lack of political will. It's not considering these people as human, but as numbers. That's why we come into a result that I'm going to share with you just now. I'm going to share with you the experience of Greece. When COVID appeared in Greece in 2020, migrants and refugees were the first one to be locked in the camps, considering that we want to protect the local community, while migrants were not the one to bring the COVID in Greece, where the Greek tourists coming from Milan, when they went to buy leather coats, who brought COVID itself. So the country introduced measures, introduced a restriction of movement. While those restrictions of movement during the period of time relaxed for the local population, they did not change for migrant and refugees. So they still remain in the camps. So first of all, as part of that result, information was shared only on the Greek language, very few information on different languages. Secondly, they were kept locked in the camp where situation had been horrible, and situation that if during COVID time, when we discuss keep distance, wash your hands, and try to wear a mask, was something that was not possible to be implemented in those camps. Our data that are also published in the Lancet showed that the impact of COVID on the migrants and refugees living in the camps on the Greek island was 3 times more than the local population. The impact of COVID for the migrant and refugees living in the camps on the mainland was 2.5 times more than the local population. So we have already an impact of COVID itself on those people with no reason for the purpose. We could minimize that exposure. So when it comes to the vaccination, by the end of 2020, the Greek government declared that refugees and migrants living in the camps is a priority population. That would be the first one because they are exposed to more risk, overcrowding population, bad living conditions, area that COVID can be much easier transmitted. So it took the Greek government 6 months to start the vaccination of migrant and refugees living in the camps. That means today, if we are talking about 75% of the Greek population being vaccinated, we talk about 45% only of migrants and refugees who are living on those facilities managed by the government. And then I have to add on the top of that, the undocumented migrants. Undocumented migrants, it took us months, not to say a year, first of all, to advocate for them. Secondly, to consider that those are human beings that are not numbers. And thirdly, to be able to ensure that the Greek government issued also a legal frame not to deport those people while being vaccinated, or those people have the right also to be vaccinated even though they don't have the proper documentation, and also to ensure that the NGO community can vaccinate. So the Greek government is not taking responsibility to vaccinate undocumented migrants, but is asking the local, the NGOs to vaccinate the undocumented migrants against COVID. So in front of this situation, we are able to bypass different barriers by activating a campaign in Greece called Vaccines for All. We did it in collaboration with the Forum of Migrants and Forum of Refugees. And this was able to, first of all, to activate a website with 10 languages. So we're able, first of all, to inform people what is COVID, why they need to be vaccinated, how they can reach vaccination, how to work on the moving those barriers for their papers, because also these were huge barriers. So we minimized, let's say, the number of people who are hesitant because they didn't have information. Secondly, we gave the opportunity to people who did not have papers to come front to get themselves vaccinated. And thirdly, we're able also through this campaign to mobilize other organizations also to push the pressure at the Greek government and to the European Union in order to ensure that those people have access to the vaccine. I think what we do not understand very well in a developed world, we don't understand what does it mean, a WHO 1948 definition of health. That is physical health, mental health, and well-being. And what we do not understand very well what public health is about. What we missed during this pandemic, but also the previous years, and we hope that next pandemic we're being prepared differently, is inclusion of everybody on the planning, inclusion of everybody on the designing, inclusion of everybody on the information, inclusion of everybody on treatment, including of everybody on vaccination. If we are not able to include everybody from the stage zero, then it's not called public health. It's called public health for us and public health for others. There are no two public health. There's only one public health. And this is something we know very well and we don't have to repeat it. So what we need to change, and I conclude with that, we need to change the way how we're looking at health, way how we're looking at people. People are not numbers. People are, first of all, humans like me, you, and everybody else. And then there are refugees, migrants, undocumented, yellow, black, green, whatever you want to call them. So I think we need to change the way of approach to that. And I think we have today all the resources. What we lack today, we lack the political will. We have the money, and I think health and public health is a responsibility of state and not the pharmaceutical companies. Pharmaceutical companies are not doing a favor to us. They are getting rich with our money, with the taxpayers' money. So I think it's important the governments are responsible to that, and we need to make them responsible for them, for us, and for everybody. Thank you.
Thank you very much indeed. Some very powerful messages there about inclusivity and universality on World Health Day. And we totally subscribe to that here at the Centre for Universal Health at the Chatham House. You know, that if we're serious about UHC, everyone, literally everyone on the planet needs to be covered for all services, and how important that is. Thank you very much indeed. I'm already getting lots of questions in, which is fantastic. It's exactly what a chair likes to see at this stage. In fact, we've got lots of competition for questions. We've got one or two people lined up, I think, to ask their questions in a moment. But I'd like to start actually with my colleague Danai Avgeri, who we should all thank actually for setting up today's session. So thank you so much, Danai. Over to you for your first question, please.
Yes, thank you, Rob, and thank you everyone for this great, very thorough presentation. I think it really connected the global picture with the regional and all issues from political to financial barriers and administrative barriers. And what I would like to focus on is we see yes, we see gaps in. Sorry, I'm listening to my voice twice. We see that we need a concerted effort among different sectors to actually have this result that we want, including law, including microplanning, and like from immigration that needs to have different processes to education and information. And I would like to ask, do you think that that instituting separate systems for migrants and refugees works better, or is it better if we include migrants and refugees in already existing vaccination plans? We see, for example, countries incorporating regularization processes whereby they decide to issue migrants with legal documents in order to be able to access. We have seen that in Colombia or in Portugal, and then we see other countries instituting separate processes in order for people to be able to access vaccination in particular. Do you think that one or the other is more effective?
Good question. Thanks, Dan. Who would like to pick that one up? Apostolos.
Yes, first of all, I believe personally as a medical doctor that we need to have one healthcare system for everybody. That means that we have to adapt then the way how we are providing the services. It depends to whom we are addressing those services. So adaptation of the model of care that is much better and useful for different communities, it works. Sometimes this idea, let's divide and provide the vaccination for refugees to NGOs because they communicate better, they do it better, and they are more effective, more flexible, etc. It is, yes, it's true, it's effective in many ways. But what is an important thing is that migrants and refugees, if they are included from day zero to a healthcare system that has intercultural mediators, people are being trained how to deal with migrants and refugees, there is no difference. Because we have been realizing in situations where from the beginning people who were integrated in the societies, they became part of the societies and they are looking for the services in the way how any local society looks at that. So I think we need to invest on our health, on education, that we need to train medical doctors, nurses, midwives, how to manage and work with different type of communities. Secondly, we need to have tools in place that are available, and WHO have been producing many of them. ECDC is producing many of them to be available. And thirdly, just to ensure access for everybody. In that case, we don't need to have parallel systems in place, because parallel system in place, it shows a diversity of things, but in reality, it's just trying to avoid responsibilities. What it is, responsibility is of the state and needs to remain with the state.
Fantastic, thanks very much. Tala.
Fully agree with Dr. Apostolos. I think we don't need parallel systems, but we also know from our experience that there will be certain populations that will be left behind. So we do need to kind of be prepared on a systemic level to reach them and to include them. And I gave examples of, for example, populations that are and a significant number in areas that are not under the control of states and are outside of the reach of health systems. And when we're looking at a global pandemic, we can't ignore that part of humanity, because COVID is everywhere indeed. So for that part of the challenge, I do think we need alternatives that kind of either support national health systems to get there, or bring in other actors to get there in the absence of health systems.
Thank you. And Jum, finally.
Yes, thank you very much. If I may add, I think I agree both with Aputos and also Taha on this. But you know, we have been trying to promote the inclusion of refugees and migrants in all policies, inclusive health system, inclusive policies, and all of this. But the change cannot happen overnight. You have countries that already done so. You have also countries that have changed their law in order to accommodate that. For example, before the pandemic, Portugal have already done so, including refugees and migrants in all the units of access to universal health coverage. Thailand have done so for all migrants, for example, to their health insurance scheme. But also a country that they still have yet to change the law. Law sometimes is not easy to change. So you see example of Colombia, as has been said earlier by colleague, they have induced the protection policy, temporary protection, where the Venezuelan could have access to service for the next 10 years. And that is as a result from the pandemic. So basically, yes, we must work in concerted effort to try to change, to provide a good example, bringing in a very good example, good practice, but it's also try to push and try to work with country to promote that inclusion. But as I said before, inclusion alone is not enough. In practice, they have to also have access to services, including vaccination.
Excellent. Thanks very much indeed. And now we've got questions from the audience coming in thick and fast as well. If we could start with Michael Strange, please. I don't know if we can promote Michael. Hello, Michael. How are you doing? So would you like to pose your question to the panel, please?
Hi, thank you very much for the excellent presentations. So the question I want to ask is, in terms of how governments and also the media, the public, talk about refugees, do we see any evidence of the Ukraine situation changing how governments see the healthcare of refugees generally?
Good, very good topical question there, Michael. Thanks very much. And Apostolos, are you sort of seeing any sort of changes in perceptions?
Well, first of all, I came from the borders of Poland and Ukraine, Moldova and Ukraine itself. So what this refugee crisis brought is nobody's talking anymore about COVID. So there's no any COVID measures, any attempt in place. So for me, in order to reach those countries, I needed vaccination certificate and stuff, but not being taken in place. So for me, I think something that we forget, even though that we are in a war setting, something that was not implemented even on a European setting is probably even a minimum measures in order to protect those people, especially being in the middle of a pandemic and knowing that the number of vaccination, it is very low in Ukraine itself. Now, coming into the perception, yes, we see a change and we have a solidarity a la carte. We have a refugee a la carte moment at the moment where we are opening our healthcare systems to Ukrainians and they can have access with no problems and they can, like any other citizen. But we forget a small thing. This can be, again, a boomerang towards the approach to migrants and refugees in our societies, because not only we are distinguishing between yellow, black, green, etc., but secondly, there are a lot of inequalities in our own countries. So I think the healthcare systems, they need to be open to everybody and not distinguish that between Ukrainians or other nationalities. So we see a change and we see a different way of approach how people now look at migrants and refugees. And I think it's an opportunity just to remind you the last year's European policies that the one who have been discriminating and criminalizing migration and refugee population and solidarity have been the governments and not the local people. So if the government shows that they are opening their hearts and their arms to the Ukrainians, people, they follow. If the governments, they put fences in the same Poland that are keeping people in Belarus or people in Greece are being pushed back to Turkey, the people, they think that the government is doing the right thing. So I think this is happening in front of our eyes. I think it's responsibility of our own communities to ask our governments that the way you are dealing with Ukrainians, you need to deal with everybody, because at the end of the story, everybody is a human.
Mm-hmm. I think we're seeing exactly the same here in the UK as well, Apostolos. So, you know, that the people, the population are much more accommodating and welcoming than perhaps government policies have been. And so therefore, obviously to change things, we need more sort of political pressure, really, don't we, to ensure that the government's hearing what the people think. So, John and Tal, I'm not sure, have you got any thoughts on, the implications of the Ukrainian crisis and whether this is making things better or potentially worse?
I think I would defer to Dr. Apostolos' opinion on this question in particular. He's very close to the sort of European setting, but I think just to underscore that public messaging has been a pretty key element of pandemic response and also failures, I think, on a global level. So it kind of goes to the point that the way information is shared with citizens, whether it's related to refugees or public health, I think that has a very important role to play in our response. So I think otherwise agreeing with what was said earlier.
If I may add also, I think from the Ukrainian crisis here, what we see is, of course, is solidarity. We see that the government, I mean the EU countries, have come up with the temporary protection where you granted refugees from Ukraine to have the same health, access to social service, health, employment, and others, the same as a local population. So that part is good, but whether it's gonna extend this to other refugees and not other nationality, that is still unclear. That I found that it's very difficult to predict, because in this crisis, you also see is people from other countries who were in Ukraine. Many students, you have many African students, where when they complain of allegation about that they don't get the same treatment. So whether that is true or not, that's meant to be looked into further. But there's already such news or information that's coming in. You also have an issue, for example, irregular migrants who are covering them. So I think that we don't know what is the number in Ukraine. Even we know the number more than 500,000 migrants in Ukraine, but what is the number of irregular migrants? Where are they? Are they providing? They got services into the same way or not? So there's a lot of more at WHO. What we do is we have the health information pillar. We organize ourselves into different pillars. One is the operational pillar. Another one is health information pillar, where we really look into that. But more information will still coming in. More assessment still have to be done into this to assist. Back to you.
Great, thank you very much indeed. So I'll go straight on to the next question if I may. So we have Helen Johnson, please, if we can bring Helen on air.
Yes, thank you very much. My name is Helen Johnson. I work for the European Commission in the new Directorate General for Health Emergency Preparedness and Response. By profession, I am an infectious disease modeler. So I do a lot of thinking about the dynamics of infectious diseases and how they get concentrated in different communities and what that can mean for transmission. So my question is this: as a mathematical modeler, I'm aware that if you have a population that is more susceptible together, they're close to one another, maybe in poorer living conditions, doing difficult types of work, there is a potential or a heightened risk of transmission within that population. So how, in practical terms, can you reach that community for supplementary immunization activities or public health interventions without giving the impression that they are causing outbreaks of disease or that they are bringing disease into community? How can we have a positive narrative of health across communities while still meeting the need where the need is? Thank you.
Excellent question. Thank you very much indeed, Helen. I can see, Apostolos, you got your hand straight up there. What's your thoughts?
Well, first of all, I think the narrative, at least in my country, in Greece, but also in many other European countries, about migrants and refugees bringing diseases, it's decreasing. It is not anymore the narrative on the bringing diseases, it's more a narrative of Islamism and terrorism and other stuff. So that is being decreasing. And in order to at least publicly speaking or speaking on academic point of view or speaking towards the media, there are enough data that are being produced by NGO, WHO, NECDC, who proves very clearly that those people are not bringing diseases. What we have data enough to show is that people, and it's World Health Organization report of 2018, that is prescribing the situation, health of refugees and migrants in European region, who shows very clearly that migrants and refugees, they arrive healthy and they get sick in the countries of transit in Europe because they're being kept in a bad living conditions. They don't have access to food and water integration, and then of course they get stress. So we have been proving very clearly from Greece that the refugee camps being financed by European Union money are being producing mental and physical health. So most of the medical conditions that were created on those camps were not existing before. So in reality, just to relate that with COVID, we have been asking the European Union and the Greek government to move out of those camps who are overcrowded, people with medical conditions and people who were, let's say, senior citizen, in order that they were more at risk, let's say, on exposure of COVID. And this is something scientifically being proven, but this did not take place. So in a way, I think what is an important thing is we need, first of all, to make our governments responsible that, that people are not getting sick because of the environment itself. And secondly, in order to prove that these people are not a danger for you, it means that you have been showing with your own data that these people are not bringing diseases. So I think the government themselves, if they come publicly and they don't come with big titles that migrants are a danger, we keep them in those camps in order not to infect the local population, while there was no case among the migrants and refugees, the case was among the local population. So in order to diminish that part, we need to change the rhetoric and the language that European Union, European Commission is using, first of all, and also other countries, developed ones, they use towards migrants and refugees. And I think it is also a benefit of our societies that if migrants and refugees, they get less exposed to diseases, also the health economics will be much better for the people, local population, but also for the refugees and migrants.
Great, thank you, Tala.
So I think in terms of messaging, it's important that we tailor it towards the audience. So if the target is a refugee, it needs to be tailored towards them. I think that there's a gender element to that as well. If the target of the messaging is the host population, I think there needs to be some kind of tailoring for that. A few things that are important to, I think, include in our messaging is that access to vaccines is essentially a human right. So I think for these populations, I think acknowledging that it is their right to access essential healthcare, including vaccines, irrespective of their legal status. And I think that's very important in that a lot of people do not have regular status, but that shouldn't matter in ensuring that they have this right to access vaccines. So I think in terms of messaging, we need to kind of integrate some of these things. Trust is another important thing, and I want to mention that firewalls between access to healthcare and immigration enforcement go a long way in ensuring that these communities are willing and able to go and get the vaccines that they need without sort of having that threat of being reported to the police, for example. And ID requirements were also mentioned earlier in the discussion. I think that can be a big barrier. So messaging around that. So it's both policy and messaging. They go hand in hand. And the gender element is important because we know that women have less access to identification than men, particularly among displaced communities. So that becomes a critical factor. If a woman doesn't have access to ID, she might not be able to go and access vaccines as well. So how can we kind of share some knowledge and information with them on some of these critical issues? So I think policy and messaging will go hand in hand here. Thanks.
Great, thanks. And Jim, do you want to come in?
Yes, I would agree with both with Tao and other colleague. Basically, I think from us here, I think we're here talking about one thing is advocacy and advocacy and advocacy that have to go at the highest level to bring in commitment and awareness, but go hand in hand and side by side to have the right message. You also have to have the right information, evidence, the right evidence. So with that, we have to bring in evidence to generate evidence-based policy development, for example. And with that, we have been talking for a long time already that refugees and migrants have not brought the disease or bring in more disease into their hosting country, but it's the condition where they live and work that that make them go into having problem with diseases or this. So with this one, I think from us here at the Real Show, what we do and are doing now is have a global evidence review that would also soon we should have a data center that provide accurate information coming in from countries on refugees and migrant health. I think that's one of the way that probably very powerful way to be able to provide information on their health status or health conditions.
Yeah, great, thank you. Now, I think we might have time just for one, maybe two questions if we're quick. So that I'd like to ask a question, please, that's been posed by Petronella Ganza, and who asks, what level of support can be given to increase confidence to undocumented migrants without them feeling they will be deported or detained due to an immigration breach? I mean, this is absolutely crucial, sort of how does one manage to encourage undocumented migrants to come and access vaccines. Thoughts on that, team?
If I may on this one, because when we do we follow through the COVID vaccination from the rollout from the beginning until throughout the whole year, and what we see is that we see a number of good examples how country deal with irregular migrants, deal with the fear that they may be deported to the local authority, to the immigration authority and be deported. So with this, we see example, even in the US, what we see is that they open the vaccination center where they do not let any immigration officer nearby. They cannot come nearby. It makes as a policy. And then we also see like in Sweden, what Sweden does is to organize a bus, a vaccination bus that go into the area where you have a lot of irregular migrants, where they know where the irregular migrants live, and keep vaccinate there, no paper required. So you see a number of countries like this in Lebanon, in Jordan, you see some similar trend that no registration, come in, vaccinate, no requirement of ID. So there are a number of examples of good practice have been going on, and we're trying to promote that to bring out more good practice that could be shared with other countries.
Excellent. Thanks very much. Apostolos.
Well, I would put also a question and under the question that was made. Why do we want to mobilize differently the undocumented, to tell them, come and be vaccinated, don't be afraid, you'll not be deported and all this stuff? Why we want to do that? Because we want to protect public health. We want to protect our health, not public health. Let's not be lying to each other. So we want to protect our health. But my question is not that. I mean, okay, you make all this achievement by telling people, come as you are, no problem, no papers, just get vaccinated, and come to your house and vaccinate you. The point is, what will happen with COVID-22, with COVID-25 and the COVID-29? Because I think we are going every certain period of time in different pandemics and different issues. And of course, if I'm going to an undocumented migrant and telling him, let me vaccinate you, but the person has also diabetes and he needs insulin. And I'm telling him, no, sorry, but the insulin I cannot offer to you. So I think the question that we bring in front of us is that in addition to deal with the pandemic now, and we need to vaccinate everybody and not leave anyone behind, but without any action, of course, everybody will be behind. And this remain behind with HIV, with COVID and with many other diseases. So for me, the question is that, yes, this pandemic needs to remind us that if we don't change the page of the book we are reading, we'll remain in black and in darkness. So change the page, access to everybody, as you have been talking, Rob, and then everything will be fine.
Right, thanks, Ryan. I'm just going to squeeze in one more question, I think. If Ruth Passman can come on, and I think you've asked one or two questions. Perhaps if you can ask your shorter of the two questions, that'd be fantastic, Ruth. We'll just squeeze you in.
Hello, yes, thanks very much. I just wanted to say that I put an example in the chat as to a scheme that I introduced in England around access. And the question is, are we gathering those examples together anywhere? I think that as Apostolos said, you know, there's a limited amount that we can do against the background of inequitable access to healthcare. However, when we find ourselves in positions of authority in terms of vaccine rollout, and there's a misconception that it is equitable and accessible for all in high-income countries, then we do feel driven to actually at least try and adjust those arrangements a little bit, which is what I did in the UK.
Great, thank you very much indeed, Ruth. And I think you were asking as well, are there all these good examples being collated anywhere, so that lessons can be shared across countries? Are we aware of a repository of these types of initiatives?
We've been trying to collect this type of initiatives in order also to use them as an opportunity. For example, the positive initiatives in Europe, Portugal, Germany, or Belgium vaccinating undocumented migrants were also positive examples from us to use it towards the Greek government, saying, listen, in Europe, they've been using this and this, and they've been positive. So in a way, yes, I'm not against, and nothing is black or white. I mean, nothing it's in that direction. But we need to use those positive experiences in order to maximize and gradually, first of all, to ensure that most of the people get access to that, and of course, combined with the advocacy element. But I think this is an opportunity also for academia, in addition to the paper who are being produced on Lancet and other papers, the academia needs to come in front. Because when the one who is in front at the moment is civil society organization that always does not have always the powerful voice. So I think we need to join forces, academia, civil society organizations, international organizations, and like this gradually with positive examples, we will change gradually the rhetoric. Maybe not for us, but at least for our children.
Fantastic, thanks, Apostolos. And John, maybe to finish with you.
Sorry, I was muted. I think for us here, we have been, as I mentioned at the very beginning, we've been working on the development of the operational guides to strengthen uptake and demand in refugees and migrant population. And to do that, so what we do, we have been collecting good practice that in different countries. We have been conducting different case studies, working with partners, with on the ground, some NGO, with IOM, UNHCR to get good practice. Basically, some of them went into the guide, the operational guide. There's also some of the practice in the interim guidance. What we're going to be publishing very soon is on the global evidence review on the immunization, where there are also a number of countries, and we are looking also to collect and publish the information on good practice and vaccination.
Great, thank you very much indeed, Joe. That's fantastic. And really, unfortunately, we are going to have to bring it to a close now. We were meant to finish at the top of our, we sort of strayed 2 or 3 minutes over. And I do apologize to people who have asked questions we haven't been able to ask in time. But really just like to reiterate some of what Apostolos was saying at the end there about us joining forces, bringing together civil society and academics and the media, very much sort of to put political pressure on our leaders to ensure that we hold them to account on all things around universal health coverage. And I think that this issue of COVID vaccines has obviously, I think, put the spotlight on how woefully badly we've been doing, really. I think it was the UN Secretary General who said at the beginning of last year that the science is succeeding, but solidarity is failing. And, this has been shown very, very clearly with COVID-19. But what we're all about here at the Centre for Universal Health is bringing people together to work on issues around the political economy of universal health reforms. And, this is just one example, but we'd very much like to work with you all to ensure that everyone does get the health services they need. And, hopefully next World Health Day in a year's time will have made bigger advances towards that. So thank you very much indeed for joining us all today, and stay well and healthy, and see you next time. Thank you. Bye now.
Thank you.